about what's new in 2019 in terms of evaluating the volume status.
Thank you very much, Jean-Louis. I'm sorry for the technical issues. I disclose the following conflicts of interest with Pulsion Medical Systems and with Chief Analytical. And let's start with what's new in the topic of evaluation of the volume status. And in fact, I will focus on the detection of preload responsiveness and on what's been published, especially during the last 12 months. You know, all these tests that have been developed in order to predict the response to fluid administration when you know that cardiac output is zero and that there is no clear fluid loss or hemorrhage, or if you're not at the very early phase of sepsis, and in such cases you know that all the patients don't respond to fluid administration and you need to predict fluid responsiveness. What's new in the field, and I will just show you some of the interesting studies that have been published over the last 12 months. Regarding the fluid challenge, it's the oldest way we have to test fluid responsiveness, and it's true that it's very easy to perform. But nonetheless, you have to have a direct measurement of cardiac output, but even more, the fluid challenge is not a test, it's not a challenge, it's the treatment itself. Once you have given fluid to the patient, you can't remove it. And so it inherently leads to fluid overload. That's why the idea of the mini fluid challenge is very interesting. It consists in giving only 100 or 150 milliliters of fluid. And today there are more and more positive and quite convincing studies. The point I would like to insist on is that it likely requires a very precise measurement of cardiac output. In the first study, published by the Laurent Muller's team, they showed that the test was pretty good to predict fluid responsiveness. But my concern with this study is that small changes in cardiac preload can only induce small changes in cardiac output that must be detected through the velocity time integral with echocardiography. And I'm not sure that echocardiography is precise enough for detecting the small changes in the VTI. I'm even sure that it's not possible in this study that's not published that we performed with Mathieu Joseph and of course Jean-Louis Teboul. We showed that echo is unable to detect precisely changes in VTI lower than 10%. That's why I think that regarding the mini fluid challenge, the point is that we need a very precise measurement of cardiac output as it's possible, for instance, with pulse contour analysis, and that's why I quote this study that was published a few months ago, and you see that it provided a very good prediction of fluid responsiveness with pulse contour analysis. Regarding the changes in the IVC and the superior vena cava diameter, the great advantage of this method is that you don't need this time to measure cardiac output. You just have to look at the IVC or the SVC, SVC with TEE and IVC with TT. It requires that you know how to do that in echo, even though it's not very difficult. But my point here is that today we have some concerns about the reliability of this test. We first have this large study published not in 2018 but 17, and in this French study with a large number of patients you see that eventually the area under the bracket with the changes in the IVC or the superior vena cava was not that good. And it was quite a bit disappointing result because 0.75 or 0.65, it's definitely lower than many of the testing fluid responsiveness. And today we have also many meta-analyses that fortunately show the same results because they included most of them the same studies. And showing that, again, the area under the aggregated RAC curve, taking all these studies together, is not that good. And again, it is a bit disappointing because it's lower than many of the other tests that are available. In this context, this study, published a few months ago, is interesting. It's a sub-analysis of the big French study I showed. It's interesting because today a lot of people use the IVC, just diameter, not its variation, to tell you if the patient is fluid responsive or not. The IVC is dilated, the patient doesn't need fluid. It's small, the patient is empty, I need to give fluid. And in this study, they showed that, in fact, the diameter of the IVC at an expiration was almost the same among fluid responders and fluid non-responders. And it's only the extreme values which were really uncommon of the IVC diameter that were able to predict fluid responsiveness. And even more, and it's very interesting also, they showed that this prediction was even worse when they studied patients with intra-abdominal hypertension, which is definitely a limitation for the IVC, not the SVC, but the IVC changes. So something that is likely important to consider today. The recruitment maneuvers are interesting because it's quite easy to assess the effects. And also you have the double effect. You have the benefit of performing recruitment maneuver and of predicting fluid responsiveness. The first study has been published by the team of Xavier, and they showed nicely that in fluid responders, the recruitment maneuvers induced a larger decrease in cardiac output compared to non-responders, where cardiac output also decreased, but to a smaller extent. And so it's quite easy to perform, provided that you have a direct measurement of cardiac output. What's new in this field, I was interested by this study by the team of Messina and Paolo Navarrese. And they performed successive size at different levels, as you can see. And they observed the changes not in cardiac output, but in the simple systolic arterial pressure, and they showed that the slope of this decrease in the SAP, along with the different size, allowed a good prediction of fluid responsiveness. And it's not very easy to perform like that, but it clearly opens the possibility of some automatization of these tests through a crosstalk between the monitor and the ventilator. So it's likely something very interesting to consider, at least for the future. Of course, it's limited by the fact that, in theory at least, it's only possible to use it in the patients in whom the size or the recruitment maneuvers are indicated. The respiratory occlusion tests are easy to assess. You just need to click on the button and to look at the screen. We developed this test with Jean-Louis Teboul now 10 years ago, and the principle is very easy to understand. It's based on heart-lung interaction. As you know, when you ventilate a patient, each insufflation increases the intrathoracic pressure, and so it tends to decrease venous return. And so the principle of the test is that if you stop mechanical ventilation at end expiration, then you increase cardiac output for a few seconds. And if the time is long enough and the preload bolus crosses the whole circulation, and if in the end cardiac output increases, it means that both ventricles are preload dependent. And in this study we showed that if cardiac output increased by more than 5% during a 15-second end expiratory occlusion, the test was positive and the patient was very likely fluid responsive. And again, in ventilated patients, of course, it's quite easy to assess fluid responsiveness, much easier, for instance, than a passive leg raising test. What's new in the field? It's likely regarding the way you can assess that. In the initial study, we assessed the effects of the test with post-contour analysis, but definitely all patients are not monitored with such devices. Is it possible to use echocardiography? In this study by the team of Xavier, that is a recent study, they showed that if you detect the changes in VTI, the test is reliable and there is a small gray zone, what confirmed our first study. But again, the concern I have is about the reliability and the precision of echocardiography, because the changes in VTI are small. This is why in the study that we published before about this topic with Mathieu Josiac, we performed some end expiratory reforms, and we expected that the increase in stroke volume would be larger in fluid responders. But we also performed some end-inspiratory holds, expecting that the decreases in stroke volume would be larger this time in fluid responders, and so that the sum of both changes would be larger in fluid responders. And the results are on this slide. You see that when we consider the increase in VTI during end expiration, the area under the RAC curve was good, but the threshold, which was compatible with the threshold we found for cardiac output, was 4%. Really too small for the echo detection. While when we added both a 15-second end expiratory occlusion and a 15-second end inspiratory occlusion and added both effects, the area under the RAC curve was good also, but the threshold was higher and likely more compatible with the precision of echocardiography. And a few months ago, we showed that it's also possible to do that with esophageal Doppler, which is interesting, especially in the operating room, where the OR ventilators today can perform these expiratory and inspiratory occlusions. So it's easy to perform. It's impossible if you have a too strong respiratory effort from the patient and if he is unable to tolerate this strong expiratory occlusion. What's new about passive leg raising? The advantage is that definitely it is well demonstrated, but the main drawback is that to assess the effects of passive leg raising, you need a direct measurement of cardiac output. And you need even a real-time, a precise and real-time measurement of cardiac output. So which monitoring devices could you use for this purpose? Many of these devices have been used. You can use pulse contour analysis, okay, precise and real-time. You can use esophageal Doppler again. You can use the changes in VTI with echocardiography, and the changes are larger, so you can rely on echo to assess the changes. Capnography is likely something interesting and non-invasive. You can use bioreactance, vascular Doppler. I'm not sure it works really. And I will share with you some data regarding plethysmography and the perfusion index. Because you know this signal that you have on the monitor of all of our patients, in fact, is made of two components. There is a pulsatil part, which is related to systole, and there is a diastolic, non-pulsatil portion. And the ratio between both, which is called the perfusion index, can be automatically measured with the radical 7 Massimo device. And it is logically related to the vasoconstriction, or the vasomotor tone, and if there is vasoconstriction, as you know, the SpO2 amplitude will decrease. But it's also related to stroke volume. And that's why we wondered whether it is possible to follow this perfusion index to assess, for instance, the changes in cardiac output during a passive leg raise. And in this study we performed with Alexandra Bertrand, we showed that actually in a prelude responder, you see that during passive leg raising and during volume expansion, this perfusion index, simply displayed by this radical 7 device, followed the changes in cardiac index, and it doesn't move in prelude non-responders. And eventually the area under the RAC curve was good and the threshold was close compared to the threshold we found previously with cardiac output. It's only one study, and also we had to exclude some patients because of unstable signal, because of absent signal, but slightly there is something interesting. And let me make the teasing of the presentation of Frédéric Michard a few minutes ago that will also, I think, show very interesting results, again with plethysmography and with this perfusion index, so there is likely something interesting there. Finally, regarding passive leg raising, there has been the question whether it remains valid in case of intra-abdominal hypertension, because it's been suspected that in case of intra-abdominal hypertension, the crush of the splanchnic compartment could reduce the volume of blood that is mobilized. It's been suspected by this study, and actually we definitely demonstrated that in this study that in fact is in revision for the moment. And we showed that, look, In patients with intra-abdominal hypertension, the increase in passive leg raising, although they were responders, was less than in patients without intra-abdominal hypertension. A reduced increase in cardiac output in case of elevated intra-abdominal pressure. And more importantly, this definitely led to some false negative cases because we had some patients who were fluid responders, but who were non-responders to a passive leg raise. These were definitely false negatives. It was not all the patients, but at least I think that today we can say that the passive leg raising test is less reliable in case of intra-abdominal hypertension. Thank you very much for your attention.